to take a stab at this. My name is Roy Kemp. I'm the Deputy Administrator. I'm the Deputy Administrator of the Quality Assurance Division within the Department of Public Health and Human Services. We administer the registry, a position that I've had in the last 7 years. So I've been with the program since its inception. I think I understand the instruction of the chair. And the department rises in support of 423 as amended by Representative Noonan, and I rise in opposition to the bill as amended by Smith. How would you like me to proceed?
You will be a proponent.
Thank you. As I stated, my name is Roy Kemp. I'm the Deputy Administrator of the Quality Assurance Division. I have been administrating this program for 7 years. I would like to point out that the department supports the return to one doctor for patient recommendations. It has been my experience that most individuals are uninsured and use ER services or urgent care services for their medical needs. I know this because I receive many phone calls from patients who are seeking a doctor because they are of an economic class that they don't maintain a primary care physician, and so they would like to know, where do I find a doctor? And I am unable to provide them with that information. Urgent care or ER services are expensive. Out-of-pocket cost for patient exams, diagnostics, testing for this type of folks is rather prohibitive. Add a second physician to it and require a set of diagnostics with a second physician, it is extremely prohibitive. Most of the people I speak with on the registry would not be able to afford that standard of care. Most would return to the black market to acquire their medicine because they've told me so. The first conflict that I see appears in page 4, section 8, and I don't know whether that's an accurate statement because I do not have a lined bill. I have the, I don't know which document I'm working from, but the section requires the department to provide the names of registered cardholders and providers to the local law enforcement agency having jurisdiction. Difficult to determine who has jurisdiction, sheriff, local police, drug task force. But I would like to point out that on March 24th, 2011, the Department of Justice and the Department of Public Health opened law enforcement access to the Montana Medical Marijuana Registry through the CJIN's Criminal Justice Information Network. The information is now accessible to law enforcement agencies at any time, 24 hours, 7 days a week on a single name basis. The reporting requirement as specified in Section 8 is cumbersome, administratively difficult, and unnecessary as law enforcement already has access now for the last 2 weeks to the registry for a name-by-name basis of check. New Section 5, provider requirements. In this section, providers are now ineligible, and I am speaking now in opposition to the Smith amendments. In this section, providers are now ineligible if they have any felony convictions or even a misdemeanor drug conviction. This section also requires the department to coordinate with the IRS, the Pell Grant Student Loans Program, Child Support Enforcement Agencies, the State Department of Revenue to determine outstanding obligator or obligee provider obligations. Senate Bill 423 allows the department 30 days to process cards. Fingerprint background checks as required by this section take approximately 2 weeks at a minimum to process, as we have had some experience. The department will simply not be able to meet the timelines that are established in Section 5. Number 5 of Section 5 does not allow a provider to accept any compensation. They also may not be a card holder. In other words, they cannot be a card holder patient and then also serve as a provider. The registry shows that many providers are also patients. By limiting them to serving only one card holder not relating to them, we now have to verify second degree of kinship on every application that comes in for more than one individual being named to be a provider. In my experience in operating the registry, there are many people who have called me and are bedridden, physically infirm, who have varying degrees of disabilities, are unable to provide medicine for themselves. With the new standard of felony or misdemeanor offenses disqualifying providers, it is likely that many of these one-to-one patient relationships patient relationships will no longer be acceptable. What I'm talking about is there are currently 4,848 caregivers on the registry. 4,776 of those caregivers are also patients. That leaves 162 people who can serve as caregivers in the pool that you're talking about. It is the Department's opinion that these amendments taken in their entirety on providers will eliminate the vast majority of the one-to-one relationships currently in practice. It will severely limit access to providers and medicine. It will force patients back to the streets and the underground markets. The Department would recommend increasing the number of patients served by providers to another number. 50 would come to mind. It would be an improvement to patient access to a limited pool of acceptable providers. As you limit the amount of people who can willingly come forward, put their private lives out and say, I have no misdemeanor convictions or no felony convictions, I'm willing to do this for you on a one-to-one relationship and I won't take any money for it, is pretty much a death toll to the one-to-one relationships. It leaves 162 people who are not patients, who are acting as caregivers now, but it might eliminate them as well, because if they have a misdemeanor drug offense in their record, they are eliminated as a provider of service. New Section 8, healthcare providers, requires a cardholder to remove cannabis before admitted to a healthcare facility. It requires the cardholder's provider to control the marijuana and return it to the cardholder or remove it to the cardholder's home. And if no one else is available to secure it, law enforcement would take possession of it. The difference being law enforcement would be ordered under this to destroy the product. This is in conflict with Section 16 of these amendments, in which law enforcement must return confiscated medicine to a valid cardholder upon verification of a cardholder status and finding that they are legitimate on the registry. I would say to you that because a patient is in the need of an emergency room service, is within the lawful content, has 1 ounce, is met the law in all regards, would now have their medicine destroyed by law enforcement through no fault of their own. Another unintended consequence is that while an emergency room is trying to determine whether an individual can get rid of the product, they could very well face an EMTALA, which is an emergency medical treatment and advanced labor practice violation. You have to triage, stabilize, and treat or transfer a patient in a very short period of time. Most cardholders will be seen in emergency rooms. Hospitals, by their bylaws and facility policies, can dictate how they would proceed in these cases. Hospice exception, as noted in both amendments, is problematic. There are only 12 inpatient hospice beds in Montana. The way I read the amendment, it indicates that hospice is accepted. But with 12 inpatient beds, what it means is that there's 35 other hospice programs that provide their services to people where they live, in their home, in a retirement home, in an assisted living facility, nursing home. All of those would be eliminated by the Act as they are licensed healthcare facilities. As an example, if your mother had been living in a facility, an assisted living facility or a retirement home at the Waterford for the last 3 years, suddenly was diagnosed with cancer, her physician recommended cannabis use for the control of nausea brought about by chemo and radiation treatment, she would have to be discharged from the facility in order to avail herself. She would actually have to move into a motel or someone's private home in order not to be in a licensed healthcare facility. Licensed healthcare facilities operate under policies and procedures and are free to dictate whether they will or will not, and under what circumstances they would accept serving an individual. I would recommend that this section be clarified. There are only Section 8 prohibits the use of medical marijuana in licensed healthcare facilities. It creates a conflict. Hospitals can regulate themselves. The assisted living and others can also regulate themselves. We simply ask them to develop policies and procedures. When you move into an assisted living facility, they sign an agreement, a contract. That individual can, in that contract, say that we prohibit the use of medical marijuana in our facility, will never allow its use, and it's taken care of, and it's done on an individual basis, and it allows an assisted living facility or retirement home that has been caring for individuals for a length of time to be able to continue to provide that level of care.
Please summarize, sir. We have others that will need to speak.
I believe that was an unintended consequence to the action, and I would request that that it will be remedied or addressed. I will close and summarize by indicating, once again, the department finds problems with both sets. However, we rise in support of the Noonan amendments. We rise in opposition to the Smith amendment. I am available for questions.
Thank you.